Hello, everyone, and thank you for joining us for this special virtual event promoting midwifery and high-value care in Medi-Cal. We're really delighted you're all here to join us today, and we're going to be getting started in just a few minutes. So for those of you on the call already, your lines are muted to reduce background noise. Thank you, and we'll be right back. Good afternoon, everyone, and thank you again for joining us for this special virtual event promoting midwifery and high-value care in Medi-Cal. We're really delighted you're here to join us. In today's webinar, we'll feature PBGH's Blair Dudley. And as a reminder, this session is being recorded and will be available to you after the webinar is complete. We'll be sending the presentation slides, the recordings, as well as URLs and resources mentioned via email. At this time, I'd like to turn it over to Blair.
Thank you, Michelle. Good afternoon, everyone. Welcome to PBGH's maternity webinar, Promoting Midwifery and High-Value Care in Medi-Cal. I'm going to wait just one moment for us to hit 12 and get folks on. And it looks like we are now at noon, so we will get started. Thank you for joining our presentation today. My name is Blair Dudley, and I lead the Transform Maternity Care program at the Pacific Business Group on Health. We're here today to discuss payer practices in maternity care, and specifically health plan practices and policies regarding midwifery. From the Listening to Mothers in California survey, we learned that women want a choice in their care team and care location, including midwives, birth centers, and doulas. Moreover, women who use midwives have fewer medical interventions such as C-sections and positive quality outcomes such as high rates of breastfeeding. However, despite these findings, it's estimated that only 9% of births in California are attended by a midwife. So today we'll discuss health plan strategies to promote the use of midwives and other ways to encourage high-value maternity care, such as quality measurement, focusing on maternal mental health, and bundled payment. Because PBGH believes that these high-value strategies and increasing midwifery utilization will improve the quality, affordability, and the patient experience in childbirth and maternity care. We thank you for joining and for engaging with us in today's presentation. You will learn about current health plan policies in maternity, and you will leave with several recommendations and resources to promote the use of midwifery in your networks and practices. Although your lines are muted, we invite you to ask questions throughout the presentation using the chat box. We'll save time at the end to answer questions, and we'll be sharing slides from the presentation following the meeting. We would like to express our gratitude toward the California Healthcare Foundation and the Yellow Chair Foundation for their funding and support of this work. And before we dive into the content, I'd like to turn it over to Michael, who will walk us through a few quick tips and tricks regarding our Zoom platform.
Thank you, Blair. And thank you everyone for joining us again. So before we get started, I just wanted to review a few Zoom tips with everyone. As we mentioned, all attendees are muted upon entry to ensure no background noise is coming through. Please refrain from using the hold button as we do not want to hear background music. If you have any questions, again, please utilize the chat box. We will gather all questions and answer at the end of the webinar as much as time allows. But just a reminder that a transcript with all questions will be sent out along with resources after this webinar. Lastly, if you have any technical issues, please use the chat box and speak with Michelle, and I will help you as best as she can. And this next slide is just a quick control guide. We'll leave it here for a moment, and then we can continue on.
Great, thank you, Michael. So before we jump into the maternity content, I want to provide a little bit of background about PBGH. So the Pacific Business Group on Health is a nonprofit coalition of private and public purchasers working toward a vision of a healthcare system driven to deliver the best health outcomes, experience, and affordability for consumers and purchasers. And within PBGH, the Transform Maternity Care program is dedicated to promoting high-value maternity strategies and developing programs to support purchasers, providers, payers, and patients on their journey. I'd like to thank our Care Redesign team for their commitment to this and other maternity projects. Again, my name is Blair Dudley, and I'm joined today by my colleagues, Michelle Ma and Michael Au. Now, since we expect folks from a wide variety of institutions and backgrounds to join this call, we'd like to begin by asking, which stakeholder category do you belong to? And at this point, you should see a pop-up poll on your screen. Please select one of the categories. Wow, we do indeed have a very broad audience today. Thank you all for joining. So no matter what type of organization you're joining us from, we think that what we're sharing today will be helpful to a variety of stakeholders. And with that in mind, we'll accomplish a few key objectives today. The first is reviewing the variation in payer practices regarding midwifery in California. Second, we'll discuss what can be done to drive improvements in maternal health, including value-based care strategies in Medi-Cal. And lastly, we'll discuss our recommendations for promoting midwifery in managed Medi-Cal and Medi-Cal fee-for-service. Following the meeting, you'll receive several resources, including these webinar slides and the recording, and answers to questions posted in the chat box. You'll also receive our issue brief, Promoting Midwifery and High-Value Care in Medi-Cal, and our recommendations one-pager, How Payers Can Promote Midwifery. So to provide a little bit of background on how we're coming to this material to present to you today, this last fall, we interviewed California Medicaid or Medi-Cal plans across managed care models and geographies to explore opportunities to promote Medi-Cal access to midwives and high-value care strategies in maternity. And in order to capture the full landscape of payer practices, we also interviewed large commercial health plans. So today, we'll be sharing our interview findings as well as some recommendations. So we began by identifying a few specific levers that health plans have, including network adequacy and contracting, reimbursement rates, and consumer access. And with these levers in mind, we asked health plans questions like, do you contract with midwives and birth centers? Are midwives listed in your provider directory? And what are the reimbursement rates for midwives and birth centers compared to that of an OBGYN and hospital birth? So let's dive into our findings. We interviewed 12 health plans, and what you see on this slide are answers to some of our key questions around contracting and the visibility of midwives and birth centers to consumers. We learned that almost all health plans contract directly with midwives and birth centers. However, you can see a few gaps here, and there are some reasons why. So many health plans are unable to determine the exact number of midwives providing care in their networks because of the delegated arrangements and because of billing complications. Also, several health plans noted that their delegated medical groups, community clinics, or network hospitals may have nurse midwives on staff, but the claims often come in under the physician's name. This is because billing midwifery services incident to a physician often means a higher reimbursement rate, or the claims simply automatically show up under the delegated entity. These logistical and financial reasons make it hard for health plans to determine exactly how many midwives are effectively in network or attend births for their population. We also asked health plans about consumer access. Midwives need to be not only available in Medi-Cal networks, but they also need to be a visible option to women seeking care. We learned that 92% of the plans interviewed have at least one birth center in network, and 83% contract directly with midwives. We also learned that 67% of the plans interviewed list midwives in their online provider directory. This finding is encouraging since these online directories serve as a menu of options for consumers. However, since plans often do not have full information about the midwives delivering services in their networks under delegated arrangements or in clinics and hospitals that employ midwives, it could be hard for consumers seeking midwife care to find it using these directories. Now we'd like to turn our attention to reimbursement. While we learned that most Medi-Cal plans contract with midwives and include midwives in their provider directories, when we asked about the actual reimbursement for midwives, we discovered there is a range in payer policies. Several plans reported reimbursing midwives at the same rate as physicians, with the caveat that the actual rate varies by contract. For example, 100% or some slight variation of the Medi-Cal fee-for-service rate. However, other plans reported reimbursing midwives somewhere between 80 and 90% the rate of reimbursement for physicians. Regarding birth centers, health plans consistently reported lower rates of reimbursement for birth centers compared to hospital births. Many of the plans noted that for birth center births, the professional fee is the same or similar, but the facility fee is less, since it's based on simply the APR, DRG, and the per diem rate. Overall, payers estimated that birth center reimbursement in total was anywhere from 30 to 50% less than that of hospital reimbursement. So this was a really critical finding because birth centers are a fundamental source of midwife-led care, and these findings speak to the financial challenges facing birth centers. Simply put, it's very capital intensive to start a birth center and very hard to keep birth center doors open because of this differential in reimbursement rates compared to hospital births. This puts an overall strain on consumer access to midwives and speaks to the challenges to grow midwifery practices. Now we'll look beyond contracting and reimbursement, and we'll turn our attention to some of the other ways payers can facilitate change in maternity care. Network requirements coming from either new policy regulations or from health plans themselves can greatly encourage change in the industry. The binding guidance of the All Plan letter from December 2018 ensures that at the very least, Medi-Cal plans must attempt to contract with at least one certified nurse midwife, licensed midwife, and birth center. While there is a lot of room to improve and expand this very basic network requirement, this All Plan letter was a significant victory for Medi-Cal families who are looking to access a midwife for their maternity care. Another important strategy for health plans is to promote professional standards and drive improvement in their networks through quality measurement and data transparency. Public reporting not only promotes healthy competition among providers, it also educates consumers on their care options. And promoting high quality is aligned with promoting midwifery and physician-midwife collaboration, since studies have shown that areas with more midwives integrated into the health system have significantly higher rates of physiologic birth, less obstetric interventions, and fewer adverse neonatal outcomes. So, health plans mandating quality standards could encourage more practices and hospitals to use midwives and to promote physician-midwife collaboration. Health plans can also utilize performance on quality metrics as a network requirement, and we encourage health plans to work with purchasers to ensure high standards in their networks. In particular, in California, we recommend that health plans encourage hospital participation in the California Maternal Quality Care Collaborative, or CMQCC. Several mom and baby quality metrics are reported on the consumer-facing site Cal Hospital Compare. And in fact, this past summer, Cal Hospital Compare added a new measure tracking the % of deliveries by certified nurse midwife. Although this metric does not yet have a target, this is an important measure for consumers and the health industry to be aware of. Aligning contracting standards with quality targets sends a strong message both to the provider community and that purchasers and consumers demand high quality and refuse to pay in-network rates for anything less. And now let's hear from one of our health plan interviewees, Partnership Health Plan, who will share a bit about their best practice to leverage CMQCC data. Dr. Moore, thank you for joining us.
Thank you. Can you hear me okay?
Yes, thank you.
Great. So I've been asked to speak a little bit about our hospital pay-for-performance program, what we call the hospital QIP, which has been in existence for approximately 7 years or so, in which about between 2 and 6% of the income that a hospital gets is potentially available for incentive payments. Not all hospitals in our region are eligible. They do have to, go through it has to be agreed upon in the contracting phase. But this has become a standard that we try to aim for with all of our hospitals. Early on in that process, we did have a measure that just said join the CMQCC and get a certain number of points for that. And we basically have a number of measures, approximately between 5 and 12 measures depending on the size of the hospital, and they would be assigned points for achieving each threshold. And so the pay for participation was the first goal. And then over time, we switched to paying for achieving certain goals and outcomes, but that those goals and outcomes would only be accepted if they were reported through CMQCC. And we developed a contract with CMQCC to send us that data directly for all the hospitals participating in the pay-for-performance program. And those 3 measures related to maternity care are exclusive breast milk consumption at hospital discharge, the nulliparous term singleton vertex C-section rate, and the early elective delivery rate. So those are the 3 measures that are eligible for extra payments. I did want to add, we do have, in the last couple of years, we've added another pay-for-performance program for prenatal care providers. We call it the perinatal QIP. Not all providers are participating. Again, there's some requirements, but we have just 3 measures for that: vaccination in pregnancy, timely first visit, and then a timely postpartum visit. And then lastly, we pay for performance helps for some people, but not others. So we are also engaging in a very deep engagement effort to meet with our perinatal providers throughout all of our 14-county region to individually go over the new and changed measures which are coming through NCQA and other quality measurement groups. And this is a great way to engage with small providers and for providers that, because of contractual reasons, may not be participating in the pay-for-performance program. And we found this is a good complement to the pay-for-performance program. And later on in the question and answer, I'd be happy to answer any questions about the programs.
Great. Thank you very much, Dr. Moore. We really appreciate you sharing how partnership has created these significant financial incentives tied to hospital performance on CMQCC metrics. It's a really wonderful strategy to encourage high performance. So health plans have a big responsibility, as we can see, to set professional standards in their networks. And particularly in managed Medi-Cal, health plans also have to respond to local issues. So we'd like to invite another of our health plan interviewees, LA Care, to share their experience responding to local issues in the maternity population in Los Angeles County. Dr. Seidman, are you on with us? Dr. Seidman, are you able to hear us? Okay, well, we'll check back later on in the webinar to see if we can catch Dr. Seidman. For those of you who are interested in hearing more about how LA Care is responding to some of these local issues and really demonstrating a great example of how health plans can get involved in local issues, we'll direct you to our publication of the issue brief, which will be shared with everyone following this webinar. So at this point, we'd like to then move to one of our next topics. Oh, actually, hang on. Let me see. Dr. Seidman might be joining us, so we may pause just one moment.
Yes, hi, can you hear me now?
Oh, great. Thank you, Dr. Seidman. We appreciate it. Thank
you.
No
problem. Yeah, so happy to respond briefly. I I had said earlier, hats off to Dr. Moore and all the great work they're doing up at Partnership. You asked me to speak briefly about our efforts to partner with our county Department of Public Health. So this is it's a work in progress, but we have a strong partnership and work with public health to support their efforts wherever possible. And there's so much overlap with the types of issues we work on. Today, we'll be talking about, I want to just mention a brief experience with our efforts to support them with congenital syphilis, but we're also in conversation with them about lead screening, in part in response to the recent state auditor's report on insufficient lead screening efforts statewide, and things like fluoride varnish that's included as a benefit, but we know that our network practices are not significantly applying fluoride varnish in their practices. But with respect to congenital syphilis, the county health officer called me last year. They were considering increasing the level of their recommendation to do both third trimester screening and promoting awareness of and supporting screening at delivery. And I wish I could say that we accomplished more. One of the things we accomplished is we found that we have significant challenges with data collection, which I'm sure does not surprise many people on the phone. But we were trying to determine what are the screening rates with the first prenatal visit, third trimester, and at birth. And we shared the results we got, but at the end of the day, I don't think they were terribly useful to the county because we know there remain some significant data challenges. To my knowledge, the county did not step up its requirement for mandating third trimester screening, but I do know that it was helpful for the county health officer to know what we did to promote awareness of the recommendations to screen for high risk, which includes virtually all of our members. So that's one way in which we partner with public health. And again, I'm happy to answer any questions that might come up later.
Thank you very much, Dr. Seidman. And I'll just remind folks, if you do have questions, since your lines are muted, to please enter them into the group chat and we'll capture those and have time at the end to address them. So thank you very much, Dr. Seidman. Clearly, health plans play such a vital role in the health of local communities. And as you said, even tackling such challenges, and dealing with issues with data collection, it can be extremely impactful for health plans to be a source of promoting awareness of certain issues and getting some key education out to both patients and providers. So in addition to some of the quality and safety and some of the more kind of traditional screening rates and metrics that we've been discussing thus far, health plans are increasingly turning their attention to behavioral health in maternity care. And this is in response to both consumer advocacy efforts as well as new policy regulations. There are 2 new assembly bills which require changes at both the medical group and the hospital level, requiring providers to screen for behavioral health conditions and to create programs to treat perinatal mood and anxiety disorders. And I'd like to highlight a new opportunity for hospitals to join the Perinatal Mental Health Learning Community, which is a program created by the Hospital Quality Institute and California Healthcare Foundation. And this will provide support to hospitals in their efforts to strengthen perinatal mental health. So this is, as you're seeing on the screen, in response to California Assembly Bill 3032. In addition, health plans are responding to this focus on behavioral health in a few different ways. Many are attaching incentives to performance on perinatal depression screening, and others are developing care management resources in-house to support providers in their ability to screen, treat, and refer patients to treatment. So let's hear from Linda Mako at Aetna, who will tell us a little bit about their maternity program and how they're focusing on behavioral health. Linda, are you on with us?
I am. Thank you so much for this time to share how our Aetna maternity program nurses help people on their path to better health. And at Aetna, I speak to our women's health programs and provide clinical support. And our nurses in this program are all trained obstetrically, and they assess members if they have a history of or if they currently have any behavioral health issues so that we can case manage them closely. And our team includes an embedded behavioral health specialist. She works very closely with our nurses and our members to address their behavioral health and their pregnancy needs in a very personalized way. This includes during pregnancy, and we manage members out to 4 months postpartum. And including a very convenient way they can call in or secure email their nurses at any time. For our members, we do depression screening during pregnancy and during our 2 postpartum calls that are scheduled. We certainly work with them more frequently if that's appropriate. And in addition, we accept referrals from a program we have here at Aetna called the Guardian Angel Program. It is a pilot. And this is where we support members who recently survived an overdose. And we have specially trained nurses and clinicians reaching out to them and sometimes their caregiver. Our focus is to get them the care, the treatment they need to recover. We provide resources, support, harm reduction strategies. We monitor them to make sure they're following up. And for the members who are pregnant, they refer them over to our program to ensure that that connection to case management's in place. So for all of our members, of course, we're doing our depression screening and referrals, education and coaching throughout pregnancy and postpartum. But for our members who have opioid use and risk of neonatal abstinence syndrome, our nurses are consulting with that behavioral health specialist we have for outreach, and we focus our case management and care coordination in a very non-judgmental way. Of course, we're bringing in and helping them connect with any behavioral health programs also. And we as we're transitioning members from our program, we look to the next best program, especially with our members with opioid use or history of opioid use, to coordinate continuity of care to address behavioral health need. Warm transfers, we want to be confident the member is connected with the next support they need going forward. And we are very committed here to providing at-risk members support they need during the pregnancy, postpartum, and into the future. So thank you again for being able to tell you what we're doing here at Aetna.
Thank you very much, Linda. Finally, we'd like to highlight a key strategy to reward value over volume in maternity, which has been tested in the commercial space, and that is bundled payment. Although there's no consumer cost sharing in Medi-Cal, some of the learnings from the implementation of bundled payment in the commercial space we think could translate into the public space. Since bundled payment encourages payer and provider collaboration, resulting in several key benefits, things like using a blended case rate to pay the same for all births, regardless of mode of delivery, removing incentives for unnecessary medical interventions and encouraging physiologic birth, promoting the use of midwives, and shifting funding to enhance prenatal and preventative services. In interviewing these 12 health plans, the big challenge that we heard with a bundled payment strategy in Medi-Cal is that contracting is not standard throughout the state, and each provider organization and hospital contract is unique. And delegated arrangements within plans make this even more complex. Still, PBGH believes that a bundled payment strategy could help bring about the payment and quality improvement changes we want to see in maternity care and Medi-Cal. So now that we've reviewed our findings from our interviews, we'd like to share our recommendations to promote the use of midwifery in Medi-Cal. These next two slides are the most important to pay attention to, and we'd love to hear your reactions and questions in the chat box. We want to say and recognize as well that there are significant barriers to midwifery integration in California, including, and as we've heard from some of our participants, the lack of transparency and in delegated environments and data collection challenges, the financial considerations given physician supervision regulations in the state of California, and the fact that change is hard, and evolving from a physician-centered maternity experience to a culture of physician-midwife collaboration or midwife-led care is not a simple process. But given these challenges, we'd like to share a few key recommendations, and we'll begin with managed Medi-Cal. Again, please enter your reactions and questions into the chat box. We recommend equalizing reimbursement rates for midwives with obstetricians, increasing reimbursement rates for birth center births, in particular focusing on the facility fee, developing quality performance incentives encouraging midwifery utilization, so general quality metrics such as NTSV or low-risk C-section rates, or more specific quality metrics such as the % certified nurse midwife deliveries, or requiring a certain portion of an increase in CNM deliveries over a designated period of time, both for hospitals and for delegated groups. Support the full practice authority for certified nurse midwives and licensed midwives to the full extent of their training and licensure. And finally, offering the equivalent of a PPS wraparound payment for FQHC employed CNMs who do deliveries, since if an FQHC employs a CNM, they're incentivized to have that CNM do only prenatal care because they can't get the top-up payment if they deliver services off-site. And now, given that about 40% of Medi-Cal births happen under fee-for-service, we'd also like to recommend a few levers available to the Department of Healthcare Services to promote midwifery, both as a purchaser governing plan behavior and as the plan for fee-for-service Medi-Cal births. We recommend including NTSV C-section rate in the external accountability measure set and measuring disparities, equalizing reimbursement rates for midwives with obstetricians, increasing reimbursement rates for birth center births, again, the facility fee, and increasing network adequacy requirements for CNMs and LMs and accredited birth centers beyond just the one per region. And we recommend considering current physician network adequacy standards when determining midwifery network adequacy standards. So since there are a number of operational, cultural, and financial considerations regarding midwifery expansion, PBGH has developed several resources which are available to download on our website to support you on this journey. And we're looking to work with providers, payers, and purchasers to change the way we deliver care and to create new payment models to support quality improvement. So please contact us for more information to learn how we can support you. And now, we'd like to answer some of the questions and review the comments you've posted to the chat box. we'd also like you to invite you to submit additional questions at this time. And just as a reminder, any questions that we are unable to or don't get a chance to answer today will be answered offline and shared with the whole group along with the webinar materials. So I'll pause for just a moment and give folks a chance to enter questions into the chat box. And we'll get organized to answer some questions on our end. Great, thank you everyone. I can see some great questions coming in, so we'll dive on in. So one of the early questions is asking, was the midwife question for insurers a yes/no question? Because how many midwives are in network is a significant factor in access. And thank you, Mimi Niles. This is a great question. Yes, that question was a yes/no question that we asked. And I think speaks to the fact that, yes, we do have an all-plan letter that is intended to be this binding guidance to have at least one CNM, LM, and birth center in network. But the wording is still a little bit softer. And I think having just one is potentially not enough of an access measure. And the fact that health plans just need to attempt to have these providers in network, I think we'd like to see some stronger requirements in the future. So looking at our next question, this is that insurers are not talking directly to including midwives and what is covered by their plans, and asking if we can understand more about how their organizations are directly engaging with and integrating midwives into their care plans, and thinking about not just CNMs, but all midwives, so certified nurse midwives and licensed midwives. And I think, again, this is a great question. Thank you for posing it. So one of the really the biggest challenges that we heard is that, particularly in California with the delegated environment, it's really challenging for health plans to have a whole lot of insight into their networks. And knowing where these midwives are sort of nested into staffing structures is made more complicated because most of the time the delivery gets attached to the physician name. And that's hard for health plans to see anything differently within the claims. However, I think this brings up a great point that, you know, we've seen from the consumer surveys, like Listening to Mothers, and certainly we here at PBGH hear from our employer members that more and more consumers are looking for midwives. So I think the question of how can health plans make it easier for folks to access midwives, that's a great, I think, future discussion for this group to think about, since, as we know, provider directories can be a little bit clunky and not necessarily the easiest to navigate. So I have a couple of comments that are coming in, and I just want to share. So BJ, thank you for sharing this with everyone, that midwives and birth centers are still under the 10% sequester. So even though the longstanding regulation that midwives and birth centers receive the 100% of physician hospital rates, this is a great point that we're still working through this dichotomy in how to have a midwifery practice versus how to have a physician practice, and just the differences in that operation are really a hindrance to the ability for midwives to grow in the state and outside of California as well. So in addition, I'd like to share another comment, which is, I believe, from Dr. Seidman, and this is something that we heard in a lot of our interviews. So the concern that the law requiring Medi-Cal plans to include freestanding birth centers in health plan networks without also requiring adequate supervision and contingency plans when things don't go as planned during the course of labor and delivery process. And just a request that we'd like to hear how others feel about these concerns. And I think this, again, is something that it's something that we heard a lot in our interviews, which is that we have now this all plan letter and this guidance to say we need to have these resources in network, which that's very helpful. However, there's not that much support around this all plan letter. And that looks like, you know, ensuring that there are written transfer guidelines when a transfer is needed from a birth center to a hospital. And I think we heard from both sides of the coin that it's a challenge for birth centers who are trying to maintain a financially viable practice, and yet they're running up against several barriers, and it's very challenging for them to get written practice guidelines in place, even though they're already needing to turn to hospitals when that care is needed. So I think there is a bit of a, some of it is logistical and some of it is cultural. But there's just a lack of standard practice for how do birth centers collaborate with hospitals, and what does that look like across the board. So I think this is a great point. So I just want to comment on it, that we should think about adding other quality metrics beyond patient satisfaction, such as autonomy and respect experiences, since this really matters to women. And that is certainly something that at PBGH we're interested in exploring and understanding. And we're really excited to hear about some of the patient-reported outcome measures that are in development out there. And I think just one of the challenges from the health plan side of things is that some of these measures are just very new, and we're understanding how they work and how can we measure them. But I think there's a lot of interesting work out there, and we're certainly looking for new ways that we can, again, understand patient satisfaction and understand those patient-reported outcomes. So thank you, Michelle. And it looks like we just got a note from Dr. Seidman, who would be able to provide a little bit more detail on your thoughts. Dr. Seidman, would you like to share?
Well, yeah, if there's time for dialogue, as I said in my previous comment, you know, I am interested in hearing other people's thoughts, and I see from the various comments being submitted in the chat, there are definitely people on the call coming from different perspectives on this. I guess one of the things that I wanted to point out is the what I see as a disconnect or inconsistency between what the state requires for supervision of nurse practitioners and physician's assistants. Even in an outpatient practice, they're all required to have a supervision agreement with a physician as a part of the credentialing process, but that same requirement doesn't exist for nurse midwives practicing at freestanding birth centers. And it was a major challenge for us in our internal credentialing committee. And we eventually found a way to ask the nurse midwife to submit her own contingency plan and the names of physicians that she was collaborating with in the event of untoward outcomes. So I'm curious what people think, because I would like to see a more consistent approach. If we're going to require supervision, that we do so across the board, and if we don't, that we consider eliminating that requirement across the board. But it's not clear to me that it makes sense to do it only for nurse midwives.
Mm-hmm. Thank you very much, Dr. Seidman. I think the physician supervision and requiring that backup, on the whole, what we learned both in our interviews and in some of our previous PBGH work is that really does have a challenging impact on the ability to support that full practice authority for certified nurse midwives. And frankly, from the consumer perspective as well, I think it's just hard to understand what are all of the different options and where can I get this type of care. So we've heard that patients want choice in their care team and choice in their care location, but I think it's challenging for health plans and providers alike to be able to provide that information and that level of detail, because there is a bit of a disconnect in the in that knowledge on both sides. So let me see, Michelle, are there any additional comments related to Dr. Seidman's question? So I believe we just got a comment from Roberta Frank, and I wonder if are we able to unmute Roberta's line? So Roberta, I believe you're unmuted and would love to hear your response.
Oh, thank you. Yes, we have had a birth center, freestanding birth center in San Diego for 31 years. And we've gone through the entire gamut of during the years when finding supervising physicians to sign publicly was easy. Then they became afraid of vicarious liability. They retreated. We always had a backup arrangement, the ability to transfer to a higher level of care if we needed it. And we do now, but for some physician to sign to assume liability, that's just not realistic. We have our physicians review our protocols. They are aware of the limits of our care, of how they sign our protocols every year. We have a very transparent working relationship with them. They're very happy with it, but they're not responsible for the birth center. It's a collegial type of arrangement that's very safe. It works very well. We have it with 2 hospitals and different physician groups.
Thank you very much, Roberta.
Okay. How did that sound?
I think I'd love to hear, I know we have a few other experts on the phone, and I believe BJ Snell is on as well. Michelle, are you able to unmute her line? If not, I'd love to read some of her comments.
Hi there, it's BJ. Can y'all hear me?
Yes, thank you.
Thank you. This is an area I agree with what Roberta said as well, but it is a gray area as far as midwives, certified nurse midwives that work in an out-of-hospital setting. When you're working in a hospital, the bylaws require that they be a supervisorial relationship at this point in time. However, in an out-of-hospital setting, it is very gray. But should a nurse midwife get reported, they will be, for whatever, they will get asked who their supervising physician is, and physicians are willing to collaborate, but they are not willing to quote unquote supervise in an out-of-hospital setting. And that has to do with the malpractice requirements and or just fear of vicarious liability, et cetera. So the issue with the out-of-hospital midwives is that we, are in this gray area. And midwives have been investigated by our board and been put on probation and or had their license threatened because they don't have a pure document that says there is a physician supervisor. We do have those collaborative guidelines that we've talked about and follow the law as far as standardized procedures for certified nurse midwives, but most physicians will not sign saying they are a supervisor. That's the issue.
Thank you very much, BJ. We appreciate you elaborating on that for us. So we have a couple of other comments that are still coming in, so thank you. And I'd love to, Kathleen Belzer. Kathleen, if you're on, we'd love to unmute you and give you a chance to respond as well.
Hello, can you hear me? Yeah?
Yes, thank you.
I am the president of California Nurse Midwives Association, and we have tried very hard to remove barriers that exist for the integration of midwifery in California. And the biggest one is physician supervision, because it really means a signature on a contract. It does not do anything to ensure safety. Nurse midwives are trained to collaborate and work best when we have integrated models of care. And we're trained to know when to transfer or co-manage or consult. What physician supervision does is, in small rural areas where there are no physicians, but there is a need for care, midwives cannot practice there and they cannot provide care to all of those patients who would be appropriate for midwifery care. So there is really an urgent need right now to remove this barrier. It is in no way going to make it so that the care patients receive is less safe at all.
Thank you very much, Kathleen. So I want to thank everybody for sending in your questions, and please continue to do so. Since we're getting closer to 1, and I want to thank everybody for joining us during your lunch hour, I do want to make sure and get you back to wherever you need to be before 1. And I want to just highlight, since a couple questions came in over the chat, there are, as we've been discussing, several cultural, operational, financial, and policy considerations regarding midwifery integration and expansion. And I just want to thank everyone for sharing your thoughts, because this is a really important conversation, and it's one that we are very dedicated to at PBGH. And again, we'd like to urge you to check out some of the tools that we have developed on our website. And you can please feel free to contact me, Blair Dudley, for any additional information. And again, we will be sending out our issue brief and this 1-pager of recommendations with our findings. And we would encourage you to continue to provide feedback, since this is, as we've been describing, an evolving conversation. So with that, I want to thank you all very much for joining us today. And please stay connected with us and follow us on Twitter with @PBGH updates. And again, we will be sharing the webinar slides, the recording, We'll answer the rest of your questions submitted over chat, over email, and you'll be receiving our issue brief and our one-pager. Thank you very much, everybody, for your time and for the great conversation. Take care.